Welcome, everybody, to the Cone of Shame Veterinary Podcast. I am your host, Dr. Andy Roark. Guys, I got a really good one today. This is a really interesting conversation. I have two guests on. These two are a dynamic duo. This is Dr. Sheena Warman and Dr. Kristin Jankowski, and they are both with the AAVMC Spectrum of Care Initiative Task Force. They work with veterinary colleges on integrating a spectrum of care approach into training in the vet schools. AAVMC is sort of a board of overseers for the veterinary colleges. The spectrum of care is meeting clients where they are. We talk about golden outcomes, not a gold standard. Golden outcomes is the best outcome for that specific pet in that context. And I get right into it with them about, are we training people to actually deliver this? And I hear a lot about veterinarians just getting really comfortable. And I felt this way too, about punting things. It's easy to say, well, let's send you to the specialist, or let's refer out to the radiologist to do these things. And we are getting more and more capabilities as far as what we can do. But the clients aren't always on board with that, or they don't have the resources to do those things. And I think being able to serve them means being comfortable and competent with our own hands and our own ability to get in there and get the work done. And I said that to them. I love the responses that I got. It was really great. This beautiful picture of collaboration among specialists and general practitioners. There's a lot more talk about having GP training in vet schools. I really geeked out about this. So anyway, guys, I'm gonna stop giving away all the good stuff and just let you guys check it out, because this is a good one. Let's get into it.
This is your show. We're glad you're here. We want to help you in your veterinary career. Welcome to the Cone of Shame with Dr. Andy Roark.
Welcome to the podcast, Dr. Sheena Warman and Dr. Kristin Jankowski. How are you, ladies?
Very well, thank you.
Great.
I am so glad to have you guys here. You are both on the AAVMC Spectrum of Care Initiative Task Force, which is how I met up with you, is through your work there. Dr. Sheena Warman, you are a professor of veterinary education at the University of Bristol Veterinary School. You have extensive experience working in practice as well. You have been a general practitioner, and then now you're very much entrenched in the educational side. Dr. Kristin Jankowski, you are the Director of Veterinary Services at Open Door Veterinary Collective. Tell me about Open Door Veterinary Collective.
Sure. Open Door Veterinary Collective is a nonprofit entity where we work to train veterinary practitioners and veterinary students how to provide access to care but still remain financially sustainable. So we feel that that's a really unique niche about just not always giving away care to provide access to care, but stay in business at the same time and stay happy with your work.
That's exactly why I wanted to talk to you guys today. And so you're already sort of touching on what I'm really interested in, is that balancing of care and also sustainability for the practice and quality care. But I'll get into that in a moment. Sheena, let me sort of start with you. When I came through veterinary school, the real intense educational focus was on the gold standard of care. Like, we were taught by specialists who was very much about, this is the best way to do it. This is the current modern way to do it. And that was really kind of what the teaching aspiration was. I need to show you this is the cutting edge, newest, freshest, best way to do this. And now, and I say best, I'm using that very much in the term of kind of how we were educated, was best was highest standard, most progressive approach to care. And now, we're talking a lot more about spectrum of care and access to care. And in the UK, they use the term contextualized care. I didn't come through that type of training. For me, it was, this is the gold standard, this is what you aspire to. Can you lay out for me, Sheena, like, what does a spectrum of care education kind of look like? What are the tenets? How is that different than those of us who went through vet school 20, 30 years ago? How would that look different from what we saw?
It's emerging, and I think it looks a bit different on different sides of the pond. So I'm UK based, Bristol's in the southwest of England. My background is both as a GP, but then more of my career has been as a small animal medicine specialist. So I've kind of seen it from all angles, and I've taught in the universities as a specialist for a long time. I think what brought it home to us was we get a lot of data coming back in from graduates who've been out a few years. We're very aware of the wellbeing challenges and mental health challenges in the profession, and we we were recognizing from the data that the graduates were struggling with adapting care plans to the realities of life and general practice. In the UK, the phrase contextualised care has taken off more. And when we talk amongst the Spectrum of Care team, we all really believe and know that everybody practices contextualised care. Everybody makes their care plan for the client in front of them. But if all you've experienced as a student is that tertiary level referral setting, you're serving such a tiny proportion of the wider client owning demographic. It's not just financial, it's about their motivation and ability and resources beyond money to care for their pet. That's just not the real lived experience of the vast majority of our pet owning families. So that transition then into primary care practice, which is where the vast majority of our graduates end up, is that falling off a cliff edge. Suddenly you're not just trying to apply the skills you've learned, you've got to understand that you can't apply those skills in the way that you've learned them, because that's just not possible. It's not desirable in that context always. So for me, it's been quite painful kind of recognizing that the way we've taught for so long isn't doing what we thought it was doing. It's not serving the needs of our student population, or therefore the needs of our employers, our students' employers and the graduates' employers and the public. So it's really about prepping our students so that they understand right from the get-go. We pretty much ban the phrase gold standard. I hate the phrase gold standard. And a colleague at the Royal Veterinary College, John Madison, has talked about golden outcomes rather than gold standard. And that's a nice way of looking at it. And what we want, I don't want the students feeling that offering something that isn't what textbook says is a compromise. It's not a compromise. It's a perfectly acceptable approach, that it's where you're using your professional skill set as a veterinarian to sort out the problem in front of you in a way that is acceptable to the family, to you, to the pet, co-created, relationship-based approach to work. But it's a big shift from gold standard or nothing, which is the way that inadvertently our traditional education systems have set people up.
Sheena, do you think that it is a challenge for a lot of veterinary students? Now that you said this, I think a lot of veterinary students are perfectionists. I think they want to do the quote unquote right thing, the academically correct thing. Is it hard for them to know what sort of is in the textbook and to let that go and be okay with not doing what's... I'm not that way. I do improv comedy. I am very happy to roll with what I'm dealt, and let's make this thing work. But I know that I'm probably not normal amongst our colleagues in that way, or at least I'm not the norm. Can you speak to that a little bit?
Yeah, I think it depends a bit on the student and what drives them. You know, we take in students, we take them straight from high school in the UK. They have been in an education system where they are grade chasing. It's very fact-based, their education. They've been needing to get A stars. And actually our curriculum in Bristol, we've now gone to completely pass-fail throughout to try and take that grade chasing and that pursuit of perfection out of the system. And we want them to explore what they really love and dive deep into the areas that interest them rather than what they think is going to be in the exam. I think it is hard for them. And I think for most of us, and certainly for the people that graduated sort of 10 to 20 years ago, they've had to learn the hard way. They've learned by that. So this group in the UK called the Veterinary Humanities Group have written really eloquently about contextualised care. And they talk a lot about the moral stress that you feel as a veterinarian if you only feel like a good vet if you do what the textbook says. Anything less than that, you feel like a bad vet. You're not doing what your role models, you think your role models would want you to do. Your role models would want you to do the best thing for that pet. But what you've seen is your role models in a specialist referral setting where the clients come expecting to spend a lot of money and put hours of time into their animals. So it is really hard. And the whole concept around spectrum of care is normalizing. That's not our job. Our job is not to do what the textbook says. Our job is to know what the textbook says, to know what the evidence is that's out there, and to come to a decision with the owner that is acceptable from the animal's welfare. The minimum level should be acceptable from a welfare perspective, and something that is agreed that you understand the pros and the cons and the limitations of the different approaches, but you're coming to the right decision for that pet and its wider family.
I think veterinarians probably struggle to let go of that high standard. I spent most of my career working with doctors and talking to them about making recommendations in the exam room and talking to pet owners. And my challenge was never to get them to lower the standard. It was always to get them to lean in and to work cases up and to really push to be a good advocate for the pets. And when I look at spectrum of care, I think one of the whispered sort of criticisms or concerns that people have is, are we giving veterinarians a pass to say, oh, yeah, spectrum of care, let's not aspirate this. It's like, I've got 3 people waiting for me, and so spectrum of care, well, let's just not run blood work. Let's give it some sub-Q fluids and see how it goes. Again, when we're talking about that here, of course, we're very much talking about trying to meet the pet owners where they are and get the best medicine done. I love Sheena's phrase, golden outcomes. I think that's really what we're going for. Kristin, can you speak to that a little bit when you talk about balancing that spectrum of care with sort of financial viability? But also for me, it's about trying to make sure that we're still doing good work. I think I wrestle a little bit with knowing if I do good work or not. And I can beat myself up because I didn't work a case up more. And I can beat myself up because I could have worked it up less and gotten the outcome. And so help me with that. Does that resonate what I'm saying as far as it being sort of a very challenging place, especially for a young doctor, to say, am I doing enough? Am I not doing enough? Am I doing too much? How do you help them navigate that?
Yeah, I love that you bring that up because that is a constant source of, I think, worry amongst practitioners. And I think it's just based on a misunderstanding of what spectrum of care really is. And like Sheena mentioned, it's finding the best outcomes for that client-patient pair using evidence-based medicine wherever it's possible, and usually really using critical decision-making. And I just had this experience over the weekend working with students here at UC Davis in one of the outreach clinics where we have limited supplies available, but we have all the brain power that you'd have in the tertiary care centers still with you in the outreach clinic. And so trying to coach those students on how to use the tools we had and think critically, involving the client at every step. When I asked the student, I was like, did you check what the client's goals are? And they're like, I actually didn't. I was just thinking we were going for meeting the quote unquote gold standard. And thankfully she didn't use those terms, but that's what she was implying. I was like, why don't we talk about the goals and let's talk about what we have available to us. And let's really critically think about our history, our physical exam, what we can do with the tools we have, and finding that balance that's really perfect for the client, patient, and provider. We're the trio that need to work together. And so not undercutting a client either. So not saying, okay, this is spectrum of care like you were saying, Andy, where you're like, let's just not aspirate. Let's talk about aspiration and looking at it in-house. That might be one method we use and talk about the cost for that. Let's talk about aspiration and sending it out because the client may have resources for that. Or if we're in a, for a pay clinic and we can offer financial payment options, they might be able to do more. So spectrum of care is offering that range of acceptable care, meets the client's goals, is compassionate, of course, always to the patient. We always want to do what's best for them. But we're always offering a range of options, always a more advanced option than perhaps the basic and even just getting by option, but going through the pros and cons, going through the value, odds of success. Those are the things that the clients really appreciate, knowing like, if we do this, the odds of you needing to come back are something else. You have a vomiting dog, but it's young and you saw it chew up something relatively benign, bouncing around and its belly's soft. And we could do abdominal radiographs today or refer you for ultrasound. But I see that Fido's really bouncy, took a treat in the room from the technician before I came in. The likelihood of having an obstruction is lower, not zero, but lower. So would it feel good to you? How does that feel if we go with some sub-Q fluids, maybe a Serenity injection, and a wait-and-see approach, but give me a call tomorrow or I'm calling you, knowing when the follow-up, all that stuff. So I think just all those pieces are important, and that's why all of those are in the AAVMC's Spectrum of Care Initiative guide of it's a huge guide that we came out with because it's complicated to offer the range of options, those relationship-centered communication skills. It's more than it's not just cheaper care. And that's what we want to get away from that myth. Spectrum of Care is not cheaper, take the easy road out care. I tell the students all the time, it's harder to think about spectrum of care. It involves more brain power, more challenge, more critical thinking.
Oh, I really like the way you put that. And then the guide that you were referencing, that's out and it's available for everybody, correct?
It's out on the AAVMC's Spectrum of Care Initiative website, available for download. And we talk about it, all of us at the task force, that It's a lot of materials, so you might want to look through the table of contents, see if there's a piece that resonates with you, something you need and you would like to use rather than trying to get through the whole thing from a book start to finish, because you might close it up because it's a little bit long, but there's such great information there. Everything from case examples to how to navigate change in your university level. I tell my practitioner friends that even though it's designed for universities on how to navigate change, as practitioners that are out there in the field like you, Andy, going to your job every day, it feels really good for the university system to have put this in print so you know what students are going to be learning and what universities are supporting. So you can be like, hey, I'm doing spectrum of care, and now that is the golden outcome. It's not just push it under the rug, we don't talk about it.
I will link it up so people can download the guide for sure. What language do you guys like instead of gold standard? Every time I say that out loud, I'm like, but I don't have a good alternative. Do you say textbook medicine? What is the phrase that you use?
I don't know if Sheena, we probably both have our own unique answers for this, and I think it might be a little different in the UK and US. So I usually, when I talk to either students or practitioners, like it's best outcomes that meet that client-patient pair. And that I talk about, we might offer the most technically advanced option, and that's the old term gold standard, the most technically advanced
option, yeah.
But that technically advanced isn't always the best match for every person in that setting. So that's how I explain it. But I would love to hear how Sheena does in the UK.
Yeah, I think we probably just try and move away. I love the language you use there, Kristin. And I think it's interesting because if you look at what gold standard means in medical fields, human medical fields, it's much more about the right thing for the right person. If you look at what it means, if you just ChatGPT or whoever, in the veterinary world, it comes out as expensive, technically advanced. Yes. It's a different concept in our two different professions. I don't really understand why that's come about. But again, it highlights that need. And the contextualized care language is a really big talking point in the UK at the moment. The vets who've been qualified 30 years are going, this is what we've always done. Why does it need a new word? But we know we need a movement. We need a shift in the way we're educating our students and our recent graduates so as they feel okay with it and it sits okay with them and their professional identity. One of the things that's different in the UK for us is that a few years ago now, I can't remember exactly when, the Royal College of Veterinary Surgeons, so that's our accrediting body, mandated that the majority of clinical education took part in a general practice setting. A majority was defined as greater than 70%. But you can use some of your referral settings, particularly for things like anaesthesia, imaging, because they're often, not always, but often replicating primary care skills, day one skills. But it has made all the vet schools in the UK look at how their final year clinical rotations are shaped. And many of us now are using much more of a semi-distributed model or a semi-distributed model where we're actively working with primary care practices to get our students out into environments where the veterinarians and the techs that we call nurses in the UK are trained in education. They know what the outcomes from the rotations are. They know what the assessment tools are that we're using. And so the students are just getting, as part of their formal education, a much wider range of practice settings. And our students have always been required in the UK to do 20 to 26 weeks of clinical placements in addition to their taught veterinary curriculum. So they've always had that exposure, but now we're formalising that more in terms of the focus of the learning. And we're talking a lot more about contextualised care. And I know, when I was a specialist teaching in the hospital and our students at that time probably only got 1 week of small animal primary care and a couple of weeks of charity, I would constantly be saying, well, what if they had no money? How would you have handled this if referral wasn't an option? And it took me a long time to realise that me having those what-if conversations was useful at the time, but when they look back, they don't remember what I said and what we talked about. They remember what we did. And I was in a tertiary referral setting, so we did really fancy cool stuff. And that's what they remembered. Whereas if you're having that conversation in a primary care context where you are having to figure out how you're going to manage this, but with a different sort of set of resources in front of you, you come to different decisions. So if you've got these really great primary care role models teaching you, demonstrating the joy that comes from that sort of more creative aspect of primary care practice and meeting people where they are, then that is a fabulous sort of role model and aspiration for our students.
Yeah, I really like that. That makes a lot of sense. Sheena, let me ask you this. You mentioned, sort of resistance to change from sort of the established clinicians and things. What kind of pushback have you gotten from the veterinary schools? Or is there pushback from the specialists when you say, we want to introduce this more of a contextualized care approach? I mean, surely there are some clinicians, I'm thinking of specialists who, I don't know, did everybody immediately say, yes, we should be talking more about fallback scenarios and alternative approaches? Or did you have some resistance to taking on that as a teaching model?
So that's a brilliant question. It's been really interesting. I think from my perspective, though, there was that initial, but we do contextualize care. We treat every client and animal as an individual, and we always talk about what if referral wasn't an option. And it's not until you say, well, but then that's not what you did because of the context you're working in. So it comes back to context. Context is really important. But there's also something about, we work with amazing people, the primary care educators, the specialist educators. They are passionate, they are so skilled at their clinical and their teaching roles. And to sort of be told explicitly or otherwise that as a specialist who's devoted their career to educating the next generation, that maybe the way the system is set up that you're a part of might not be optimal is pretty painful and is quite hard to hear. And so inevitably you get a bit of, I'm not sure about this. But what we're starting to find is we're starting to get specialists coming to the spectrum of care people and going, this is interesting. We need to figure this out. We need to work out how to do this differently and better. And both Kristin and I are working with specialists. I'm working with a team of cardiologists to come up with some primary care focused guidance on management of mitral valve disease. And we're co-creating, based off the AAVMC cardio guidance, but co-creating with GPs. And it's a real proper team effort. To the point that we're going, why haven't we always created our guidelines like this?
It makes my heart sing. I really like this. I think this makes so much sense. It makes so much sense for sort of turning out competent graduates. And so, Kristin, I have this sort of question for you, sort of along those lines. I saw this social media interaction, and the person who was posting was an internist, and so he does mobile ultrasounds. And he was telling this story, and he said, there was this veterinarian, and they got this case that the dog was possibly obstructed. It was vomiting dog. And so they did radiographs, and they had AI interpret the radiographs, and the AI was kind of uncertain about what should happen or if there was an obstruction or not. And so they called him to come in and do an ultrasound. And he said he came in and he looked at the radiographs and there was an obvious obstruction. And the point of his post was, he was like, this veterinarian should have referred to a radiologist to look at the radiographs instead of calling for an ultrasound. But they thought the ultrasound was the next step in the pathway. And I read this, and my whole thought was, where is the GP in this? If it's an obvious obstruction that the internist just sees, we didn't need AI. If you can look at it and you are a skilled GP and you go, that dog's obstructed, what are we doing here? But then it was like, he was funny, it should have gone to the radiologist before it came to the ultrasound. I'm like, where the general practitioner has almost been lost in this in some ways, in like, the GP is the person who decides if we're doing an ultrasound consult or an AI consult or an ultrasound. And I just think this feels counterintuitive, though, like that if medicine is going this way, if this is what technological advancement looks like, then I feel like we're moving away. Because when I think about spectrum of care, in order to be able to really deliver on this promise, I feel like we have to have general practice veterinarians that have very strong clinical skills. They need to be able to palpate abdomens and when they can't do radiographs, and they need to be comfortable doing things like going to surgery. And I'm not saying every GP should be fired up and excited about surgery, but that ability to say, this person is not able to be referred, we can try to offer care here. I worry that's kind of a shrinking skill set. And I'm not trying to put this on the younger generation. This is in my generation as well, of we've just gotten steadily more comfortable with punting things up the chain. And now, to me, spectrum of care is really this realization that maybe everything doesn't have to be referred. Maybe as long as people understand what their options are, we have the ability as GPs to do this work. Kristin, do you kind of agree with that assessment? And then do you think that the way we're educating GPs, does that need to change to keep them competent and comfortable in not throwing out a lifeline to, advanced care that maybe people can afford?
First off, I 110% agree with you on that. And that is what I noticed when I started teaching primary care at UC Davis. And not that this problem was unique to UC Davis, but to all the veterinary students who are being educated right now, is that they they were leaning on the technology too much. And so they weren't able, they would come and we'd say, what do you think of the case? And they're like, first I need a CBC chem, abdominal ultrasound, and thoracic radiographs. And I was like, let's go back a few steps. What did you feel? What did you see? Is the dog in distress? Were you able to actually look in the cat's mouth? Could it have a squamous cell in there? And that's why it's drooling and you don't need the CT. So going back and really focusing on the critical thinking, and then tying into what Sheena said, the value of general practitioners demonstrating that in the moment, that we coach them heavily on. You should do as much as you absolutely can before you refer. And not that referring is a bad thing, because referring is a good option that we have, and we're grateful to have it. And the specialists who are doing the amazing high-level technology work, we are so appreciative of them. But every referral should be a good referral where you've done everything you can to diagnose as best you can first. And just like you said, that palpation of the abdomen, I think is becoming a bit of a lost skill. And we talk about it in the Spectrum of Care Initiative, our task force, is that the primary care setups at a lot of universities are tied to the tertiary care centers. So it's very easy to kind of wander over to radiology, wander over and see the ortho specialist. And so we would we would tell the students, like, you're here until you do not wander down that hall, yet, you can. And of course, we want to do that when the option's there, but put yourself in a place where you don't have specialist care and just think. And I bet you'll get there. Did you ask another history question based on that last history question? So I love demonstrating that to students. They're like, oh my gosh, we figured out so much and we didn't even need any tests yet, or we needed just a PCV in total solids, or we just needed to do a more detailed palpation of the knee. And you can feel that tibial thrust. That dog has a cruciate. So I think these are things that we're really excited that universities all over are starting to embrace and teach, and have the general practitioners do more of the teaching partnered with the specialists. And we also feel that's super important for the specialists and the generalists to come together on a communal mission and show that mutual respect and just say, like, yes, they have a skill set that I don't have. And they kind of look to us and be like, they have a skill set that we don't have, and that we're better together. So coming at it together as a force for the students is really powerful. And we've been super excited. I've also had wonderful experiences working with specialists here at Davis and other institutions that are really, their eyes are being opened to what the students are faced upon graduation. They're like, we absolutely need to be teaching them more of how to do things without all the technology, and then with the technology too. But so they have both sets of tools in their tool belt.
That is a phenomenal answer. That makes me so happy. I really absolutely love that. I love that approach and that philosophy. I just want to restate, this is not me saying, oh, the younger generation. I was in vet school 20 years ago, and it was very much that mentality of, let's see what the radiologist thinks, and let's do a 2-view chest x-rays, the CBC chem and a urinalysis right off the bat. And that's kind of how we were taught. And again, it's definitely not this new generation. I really do think that this idea about spectrum of care and access to care is refocusing on what are the skills that really make that happen. And so I love this idea of kind of focusing back on that and using the skills that we have here in the building. It's just so much, and this is not just in vet medicine, it's in society in general. So much of the technology that we have is there to make us comfortable, and it's just so easy if you have it to go to it and go to it. And then if one day when you can't go to it, you just don't have those skills, or they've atrophied because you haven't used them in forever. And so anyway, I love that answer. Kristin, Sheena, where can people learn more online? I'm going to link up to the AAVMC Spectrum of Care Guide. I will also put a link into the Spectrum of Care Initiative. Are there other resources out there that you two really like and would encourage people who are interested in this to maybe go take a look at?
For practitioners, I think it's UK focused, but RCVS Knowledge, which they focus a lot on evidence-based veterinary medicine, but they've set up a page that is focused on contextualized care, pulls together quite a lot of the references, the definitions, and I think that's a really useful place for practicing veterinarians to start. There's also a couple of articles that Ryan Engler wrote in Journal of Feline Medicine and Surgery, which I think they're a fantastic read. Very Wonderful. Practically focused. I think they're a good starting point as well.
Kristin, what do you think?
We've been very lucky at Open Door Veterinary Collective to receive grant funding so that we can put a bundle of courses for vet students out for free to all the schools of veterinary medicine. So they're currently active in 8 schools across 3 countries. And so if the schools want to tap into those courses, they can do that. And for practitioners, we also have a whole range of courses available so people can get caught up and all the terminology, and just certainly back at the AAVMC Spectrum of Care Guide, because the resources there are so deep and amazing. So tap into that as well.
Outstanding. I will link that stuff up in the show notes. Guys, thank you both for being here so much. Thanks for tuning in and listening, everybody. Take care of yourselves, gang. We'll talk to you later.
Thank you.
Thank you.
And that's what I got. Guys, thanks for being here. If you enjoy the show, please hit that like, subscribe, follow button. And if you really enjoy the show, then, hitting that review, whatever review mechanism is in place where you get Cone of Shame, that's the one. So anyway, that means a lot to us. It helps the show out. So guys, thanks a lot for being here. Thanks again to Sheena and Kristin. Take care of yourselves, everybody. I'll talk to you later.